mostly going by the latest things in this webinar,
We are live.
Okay, sure.
Can the delegate link be shared, please? We'll circulate that.
It is there in the group, I think.
And it is there in the group.
It's there in the group.
I think we are live, Vaishali. We can
Yeah.
start.
Sandhya?
A very good afternoon to everyone. Greetings from POJS. I welcome all the esteemed guests and speakers, chairpersons, and the delegates for yet another webinar in the series of the Cutting Edge webinar. Under the able guidance of our beloved President, President POJS Dr. Meenu Agarwal, our General Secretary Dr. Vaishali Chavan, and Clinical Secretary Dr. Charulata Bapaye, we have organized this webinar in association with Vijayawada and Hyderabad societies. So I welcome you all for the webinar. Now I request Dr. Vaishali Chavan, our General Secretary, to please speak a few words and give a welcome address to everyone.
Yeah. Thank you, Dr. Sandhya. A very warm welcome to everyone, esteemed faculty and all the delegates who have logged in. This is yet another program we have got for you from the Cutting Edge webinar series by Pune Obstetric Gynec Society under the leadership of President Dr. Meenu Agarwal. And today we are really truly honored because we have with us Chief Guest Dr. Shanta Kumari, Guest of Honor Dr. Charmila, whom we are absolutely, who's an inspiration for us, and we have profound admiration and respect for Dr. Charmila, and Dr. Vidya Thobi, who is again a very close friend and a friend of POGS. We have speakers like Dr. Meenu Agarwal, Dr. Padmaja, and chairpersons like Dr. Nalini, Dr. Lakshmi, Dr. Kavita, Dr. Anant Lakshmi. And we are truly privileged that Hyderabad OBGYN Society and Vijayawada OBGYN Society are with us for this webinar today. Thank you. We can proceed. I request Meenu Madam, President POGS, to say a few words, and then we can proceed for the inauguration.
Thank you, Vaishali. And as the president of Pune Obstetrics and Gynecological Society, I welcome all of you. I welcome Hyderabad OBGYN Society and Vijayawada OBGYN Society, Dr. Shanta Kumari Madam, Dr. Lakshmi Chirumurmila. So welcome, Madam, to this forum. And then we also welcome Dr. Ananta Lakshmi Madam here and Dr. Padmaja, our another faculty, to speak on a very good topic. And I welcome all the chairpersons, Dr. Nalini, thank you for joining, Dr. Kavita, and all my colleagues here. And of course, we have our guest of honor, Dr. Charmila, who we really look up to. Very, very dynamic, very, very intelligent, very strong academically, and very strong socially as well. So thank you very much, Charmila, for joining. And Charu and Sandhya, thank you for coordinating and joining for this meeting.
I request Dr. Charulata Bapaye, Clinical Secretary, to please introduce Charmila ma'am formally.
Let us have the prayer for the inauguration, and then we shall welcome Charmila Madam once again for her words. Can we have the prayer, please?
Shubham kurutvam kalyanam arogyam dhanasampadah. Shubham kurutvam kalyanam arogyam dhanasampadah. Shatrubuddhi vinashaya Deepajyotirnamostute. Deepajyotirnamostute. Shubham kurutvam kalyanam arogyam dhanasampadah. Shubham kurutvam kalyanam arogyam dhanasampadah.
Take us from darkness to light. And that is exactly why we are here today, to learn new things about some interesting topics. And to grace this occasion as the guest of honor, we have none other than Dr. Charmila. Dr. Charmila, how do I introduce you now? We know that film stars have a great fan following, Deepika and Katrina. But I think we have a devotee following for Dr. Charmila. She is the the queen of obstetrics, the queen of IVF, the vice president of Foxy, and above all, such a polite, humble, and amazing person. I think she is one of the first persons from Foxy whom I met at my trip to Imphal. And she bonded with us so beautifully. And one more very important thing that I learned from her is her devotion towards Dr. Jayam Kannan, who's her mentor. And I think that अगर कोई गुरु शिष्य की परंपरा देखनी हो तो डॉक्टर जयम मैम और डॉक्टर चार्मिला की गुरु शिष्य परंपरा देखनी चाहिए. And the best part is that Charmila is training all other youngsters in Foxy like us also to we look at her and we realize that yes, this is how we should be with our mentor, and this is the kind of attachment and devotion we should have to our mentor who has given us so much in life. And so Charmila, really so many things to learn from you. Every time you will remember to get some nice sweetmeats from Trichy, which we enjoy a lot. And so thank you for being the fantastic friend that you are of POGS, of all of us. Thank you for taking Foxy to greater heights through your vice presidentship. You've done so much for your Trichy OBGYN Society, and today here you are to guide us for this particular webinar. Over to you, Dr. Charmila.
Thank you, Charu. Thank you so much for those kind words and sweet words, actually. Three powerful ladies you were. Dr. Meenu Agarwal, the president, Dr. Vaishali Chavan, the secretary, and Dr. Charulata was a clinical secretary for POGS. And you did such a beautiful conference with so much of hard work being put in, and we enjoyed it thoroughly for its academics. And now you're conducting with three societies, the Pune Society, Hyderabad Society, and Vijayawada Society, with great speakers. Meenu is going to talk on ovulation induction protocols for IUI. Dr. Padmaja, another good friend of mine for a very, very long time from Vijayawada, was going to speak on optimization of labor and intrapartum care. And great chairpersons, Dr. Nalini from Nasik, Dr. Lakshmi from Hyderabad, Dr. Kavita from Vijayawada, and Dr. Ananta Lakshmi, the president from Hyderabad, Vikarabad. Okay. And the MOC, Dr. Sandhya, very, very sweet person who was like coordinating it so well. I'd like to thank you for inviting me to this webinar on cutting edge. And as Meenu said, it's a webinar which has got great following because you give such great talks in a very, very precise manner. It doesn't go on, and it conveys a message effectively. And I'm honored to be called as guest of honor today. And I wish you all the best in all the endeavors of Meenu, Vaishu, and Charu. All of you are great friends. And posts do not matter for us. Our friendships, I think, will stay on forever. Thank you so much for inviting me. Thank you.
Thank you, Charmila. Thank you for all those kind words. And yes, as you rightly said, this dosti is going to continue forever and ever. And we really wish Meenu that all her dreams be fulfilled. We look forward to seeing her in bigger posts in Foxy. So I think Vidya Thobi ma'am and
yeah, Dr. Vidya Thobi will be joining later on. So we can proceed with the session. And Dr. Charmila, thank you so much. We are truly, truly blessed, to have you as a close friend. And you are truly an inspiration for us, someone to look up to. And like Charu said, someone we would like to be like you, even a little percentage of you, a little bit like you. So thank you for inspiring us.
Thank you, Vaishu.
Charmila, thank you for the blessings. Thank you for the good wishes. And as Charu ka language so bahut flowery hai. I cannot reach even the the tip of that. But I genuinely find you very, very nice, very warm, and very positive in your energies. So
and all of you are invited for the Vice President Conference in Mahabalipuram. You've all been given sessions at the same time so that you can enjoy the beach also simultaneously with the academics. Same session I put.
Yes.
Thank you.
Thank you.
Thank you. So shall I start?
Yes.
Meenu's introduction.
Ma'am, just a moment. Nalini ma'am, just a moment. Yeah.
Okay.
Yeah, thank you. Thank you, Charmila ma'am, for the kind words. So with that, we formally move on to the first session. And to chair the first session, we have Dr. Nalini Bagul. She needs no introduction. She is the director of Dr. Bagul Hospital, Nashik Fertility Center, Nashik. She was the organizing chairperson of AMOX 22-23. She was the past president Nashik OBGYN 2019-20, and many awards and a lot of publications to her credit. Nalini ma'am, and the next chairperson is Dr. Lakshmi for this session. So she is the secretary of Obstetric Gynec Society of Hyderabad. She was a joint secretary before that. She's the co-editor of Indian edition of Human Reproduction, and she's the co-editor of Foxy Focus 2022, an update on infertility. She is at present working as a senior consultant as a fertility specialist in Nova IVF Hyderabad. Welcome, ma'am. And I would now request Dr. Nalini madam to please introduce our first speaker, our beloved Meenu ma'am.
Yeah, it gives me great pleasure to introduce Dr. Meenu Agrawal, who is my dearest friend. She is right now president of Pune OBGYN Society and elected General Secretary, International Society of Gynecological Endoscopy. She holds she is an excellent laparoscopic surgeon and IVF specialist. She has made a significant contribution to the field's advancement. Additionally, she serves as a secretary at ISG, that is Indian Society of Gynecological Endoscopy. She is course director of endoscopy and ART training courses in UAE. She has trained not only from the doctors from India, but also from Germany, Bangladesh, also from UAE, Albania, etc. She is editor of Trocar Journal, and she has got many awards, that is India's Greatest Leaders by Asia One, Icon of Health by Times Group, Inspiring Gynecologist of West India, and the Foxy Champion of Foxy Award. She has authored 4 books and many chapters also. And she has over 12 publications in the international journals. That is great. So presenting to you Dr. Meenu Agrawal, who is also the candidate for Vice President. I humbly request you, all of you, to vote and support for this candidature. Over to you, Meenu.
Thank you, Nalini. I can see that your introduction came from the heart, because I just recently last week became the journal editor of the journal, the Trocar Journal, which you mentioned in your this things. Very sweet of you. So thank you very much for this very nice introduction. And we both of us did our thing together, if you remember, the bachelor's in reproductive surgery, certified. So those were like good days, I think, very good days that we did all these courses together, and it was quite nice. Thank you very much once again, and Dr. Lakshmi Madam also, thank you very much. And I'm very happy that both of you are there and both of you are fertility specialists. But the thing is, I'm going to speak on the very, very basics of ovulation induction. So you may find my talk like a nursery talk, or maybe, very basic. So please excuse me for that if you find it very, very basic. So my topic today is ovulation induction for everyone. So when we look at this particular graph, that hypothalamus is secreting GnRH in a pulsatile fashion, which is acting on the pituitary. This pulsatility of GnRH on pituitary causes a release of FSH and LH and increase in the receptors of FSH and LH. Now, this FSH will act on the ovary, and the ovary will produce estrogen, which will act on the uterus. Now, this estrogen will cause a negative feedback to the pituitary, and at some point of time, the FSH will start going down, but the follicle which is growing will be producing its own FSH. However, at a particular values of E2 in the blood, there is a positive feedback on the pituitary to cause a LH surge. So it will secrete the LH, which will again act on the ovary and will cause the release of the or the LS surge, maturity of the oocyte and the ovulation. And then the follicle gets converted into a corpus luteum, and the corpus luteum starts secreting both estrogen and progesterone, which is already acting on the uterus and making it more receptive. And if it gets implanted, it will keep it going the pregnancy. So this is just a very, very basic of HPO axis that we all know, we all studied in our gynec as well as in our MBBS. So when I say anovulation, so there are three groups of anovulation. One is a HPO failure, that is hypo group 1. Second is dysfunction, that means FSH are normal, but maybe they are PCO patients, they are called WHO group 2. And the third is when there is a premature ovarian failure, FSH is high, and that is called a WHO group 3. Now, when we talk about group 1, so how do these patients come to us? Generally, the young girl will come with the mother. She's say 14 years old or 15 years old, but she has not started with her menstruation. So because she has not started with her menstruation, the mother is worried. She brings us to us. We do the test. We do the ultrasound. Uterus seems maybe slightly smaller, but normal. Ovaries are fine. Outflow tract looks okay. You can see it on 3D ultrasound. And when you do the FSH and LH, they are low. Right, so these are the hypo group of patients, and how do we treat them? We can discuss it if there are any questions from the delegates. Then, of course, we have the PCO group, which are the FSH LH is in the normal range, but the ratio of LH to FSH is deranged, and that is why the ovulation does not happen. And the third group, of course, as I said, they are hypergonadotrophic hypogonadism. That means the FSH-LH is gone up, FSH is gone up, AMH is down, and these patients have already the ovaries are not working well for them. So whenever a couple comes to us of infertility, so how do we manage before we start with the ovulation induction process? Of course, we look at the age of the patient, BMI of the patient, and then we do an ultrasound for her, and what is the volume of the ovary? Is there any other pathology? Is there a fibroid? Is there a endometriosis? Is there a isthmocele? Is there a some kind of adhesions that we can see, or any adnexal mass? So all that has to be, a good ultrasound has to be done, and a semen analysis. So by the time we are doing the sonography for the lady, the husband goes for a semen analysis test. And suppose she's in the follicular phase, we can also do the tubal patency. You can do sonosalpingography, hyco-C, or we can do HSG. If she happens to be on day 2, you can also do FSH-LHE2. On any other day, if she comes, we can do TSH, prolactin, AMH if required. Because suppose you find that the ovaries are not looking very nice, or the follicles are very less. Any day of the cycle, we can see the volume of the ovary, and we can see how many follicles are there. And just to document it, suppose the reserve is not looking very good, we can do AMH values, or they are looking like a PCO ovaries. Again, we can do AMH values just to document our clinical findings. Now, there are 3 types of ovulation induction that we do. One is that ovulation induction for spontaneous conception, whether we are doing for IUI, whether we are doing, or in cases of PCO that we are doing. Again, 2 types of patients we have. One is that they are not ovulating. So they are PCO patients or they are anovulatory. तो उनको cycle 45 days या 2 months में आता है, and there you see, when you monitor, so they are anovulatory cycles. Or she is ovulating, but हमको IUI करने, so we want more than 1 follicle. So as to increase our chances of getting a pregnancy. So those are the patients which are super ovulation. Or the third type of ovulation is when we are taking the patient for IVF. So that is another super ovulation which we start from day 2 of the cycle. So these are the various types that we do the induction of ovulation. So when we are doing for spontaneous conception or the IUI, idea actually is to have a one good follicle or good egg. However, even if we have two oocytes up to 3, it is good in IUI cases, because then your chances of pregnancy, giving pregnancy to the couple, becomes better. So if the ovary is functional, it's a nice, she's a 29-year-old girl. She's getting her cycles every 3 to 4 months. So ovaries are good, studied with follicles. So, but no PCO, they're just studied with follicles. Then we can induce it either with clomiphene citrate, letrozole, HMG, or a combination of the two. We were stuck with clomiphene citrate for many decades. So it took a lot of courage on the part of Eshrey a couple of years ago to come out with a landmark statement that letrozole can be used as first-line treatment for ovulation induction. All right, so provided there are no other factors infertility factors which are there. So how does letrozole work? So letrozole, what does it do? It is an aromatase inhibitor. So aromatase inhibitor, so what does the aromatase do? Aromatase changes the theca cell testosterone to granulosa cell estradiol. And we saw in our previous picture that if the estrogen goes down, it causes increase in the FSH. If the estrogen goes up, it causes reduction of the negative feedback mechanism, right? So the moment the estrogen goes down, what does it do? It causes a release of FSH. Now, we say FSH and LH, but there are no LH receptors in the follicular phase. So we should not get worried why we are saying FSH, LH, FSH, LH, because FSH, LH both are secreted by the pituitary when it is secreting FSH, unless there is a LH surge. And with the LH receptors, that is only when the LH will act. Now, once this FSH LH is released, it will encourage the follicular formation in the ovary. At this point of time, we can also give some gonadotropin injections to push or to improve or to drive the folliculogenesis. Now, another thing what we have to look in an IUI cycle, very, very important, of course, is the endometrial thickness, which we will discuss later. Now, when we look at this particular graph, we can see that the primordial follicles, they get converted into antral follicles. It takes about almost a year. तो आज ही डिसाइड हुआ है कि आफ्टर 1 year कितने एंट्रल फॉलिकल्स आने वाले हैं. सो दिस इज ऑल प्री डिसाइडेड. दे डोंट जस्ट कम अप इन द ल्यूटियल फेज ऑफ द प्रीवियस साइकिल. So suppose मैंने day 2 पे I have done an ultrasound and I find these, say, 4 AFC on one side and 5 antral follicles on the other side. Now, out of these 9 follicles, which are put as soldiers on the border, we get 1 follicle, 1 or 2 follicles, which are the selected follicles, right? Out of these selected follicles, generally in a normal patient, woman, 1 follicle will become a dominant follicle and all the smaller follicles will die out. And this dominant follicle will release a mature egg. This is a very, very important diagram, because if we have to add gonadotrophins, and if we add at this stage, when we don't have a dominant follicle, then all follicles will come up. So please don't go by start HMG on day 5, day 6, day 7, day 9. Please look at the dominant follicle, and once you see the dominant follicle, that is when, if you add the HMG, you will get good results. Also, now, as this dominant follicle is growing, it is secreting its own FSH. It is also secreting estradiol, E2. Now, this E2 is causing a negative feedback, and that is how the other follicles are getting lysed or getting destroyed. So this is a very selfish follicle. It is secreting its own FSH, and वो E2 भी दे रही है ताकि that E2 will act on these follicles with negative feedback, and the body will think we are enough, we don't need any more estrogen, and these follicles will die out. So this is in the nature, it is very well controlled in a very nice way. So every cycle one follicle gets matured, and if this happens to meet a nice sperm at that time, it can get fertilized, and if it gets a good soil to implant, it can get implanted, and that is how the pregnancy can occur in a natural cycle. So when we give letrozole, how do we start? We start with 5 milligram from day 2 to day 6. Then we do the sonography. And if you want to add HMG, we add HMG only when we see a leading follicle of 14 millimeters or more. When to give the SCG again is very important. So when we are doing the ultrasound, if we already have pre-ovulatory changes, if we feel that the color Doppler, the blood flow to the follicle is a lot, or we already see a cumulus or small little fluid around the follicle, that means she's already ovulating. So if we do the LH urine test at that time or the serum LH and she's positive, so then we should not wait to give SCG and do IUI 36 hours later. We should actually do the IUI either the same evening or within 24 hours. So the ultrasound can sometimes tell us that the LS surge has already come. If the LS surge has already come, even if you give SCG, no harm, but she would have ovulated much before 36 hours of SCG. So an earlier IUI will help the patient to become pregnant. As I said, when we are looking at the ovulation, simultaneously we are also looking at the endometrium. It is important. Now, this is a grade A endometrium. We have pasted all these pictures in the OPD so that, you know, they don't say, how was the endometrium? Madam, acha tha endometrium. Acha tha does not mean anything. It could be grade A, it could be grade B. So both are acha. So it is good to put, because when we go retrospect, especially in IVF patients, if we didn't get a pregnancy, excellent blastocyst, we go back, what was the grading of the endometrium? It was grade B. So that sometimes can click a diagnosis that maybe because the endometrium was not good, or the endometrium was not reaching the cavity. So like this is zone 4, zone 3, zone 2, zone 1. So this color Doppler study again is very, very important to understand what is the receptivity of the endometrium. Sometimes we may get a pregnancy when the endometrium is not so good, especially spontaneously patient is trying, or IUI, or the vascularity is not so good. And we are very happy, oh my God, her endometrium was only 6.8, but she got pregnant. So something very nice has happened. However, we should hold our guards, because sometimes these patients are very, very prone to go for early pregnancy losses. So should not become too happy very soon. We hold our horses, wait at least till the anti-scan, and then we can be more comfortable about these pregnancies. Now, we sometimes deal that, okay, ovulation ठीक से हो रहा है, but the endometrial thickness is not good. So how to go about it, especially in IUI cycles? So we give letrozole again, like 5 days tak, then we can start with gonadotrophins. The day we start with gonadotrophins, that is the time we can add estrogen to her. Two things. One is there is already a leading follicle which is producing estrogen, causing a negative feedback and secreting in its own FSH. That is one. So giving estrogen is not going to harm this follicle. Second thing is you have already added gonadotrophins. So these two things, so wait for the follicle to become 14, 15, 16 mm. Then you can add gonadotrophins, and in a thin endometrium cases, you can also add E2 at that time. One thing which is, of course, there, it is debatable that the follicle is secreting the estrogen. So why do we give more estrogen to the patient? So sometimes we may think that additional estrogen might help, especially in a borderline thin endometrium. So there is no harm in giving, but if we give it earlier, then estrogen will act as an antagonist to the patient. It will actually not let the follicle grow. So we will get an anovulatory cycle. So the estrogen can be started, but at the right time. The other options, of course, I am sure Dr. Nalini and Dr. Lakshmi will agree with me that we can also use GCF, granulocyte colony factor. It comes in a pre-filled syringe, and just with an IUI catheter, you can inject it into the uterine cavity. Then we also can prepare PRP. I mean, I will not discuss the technique, but you prepare the PRP in your lab, and that can also be injected intrauterine to get a better endometrium. Of course, you can put the patient on CoQ, you can add low dose aspirin, you can give vitamin D, antioxidants. Sometimes sildenafil intravaginal also may be given. Only problem with sildenafil is when we give it, patient might get headaches. So warn the patient and just tell them to take a painkiller in case they get it. So all these possibilities can also be used in patients with thin endometrium. However, if they don't respond to whatever we are doing, of course, we need to probably go in for a hysteroscopy and look at the endometrial cavity and whether there are any adhesions inside which is not letting the endometrium grow. And of course, we do have a publication of an injection of hysteroscopically injection of PRP into the endomyometrial junction. So we give letrozole, as I said, for 5 days. Then we add estrogen from, once you see a dominant follicle, do the ultrasound till you find the endometrial. Suppose your endometrial lining is less, it is suppose only 7 millimeters and you have a follicle of 18 millimeters. So you want to prolong it by 2 days because you want the endometrium to grow a little better. So just a small tip, at this time, we can give her one injection of antagonist along with gonadotropins. So her LH surge will not come. So you can wait for 2 days, and on the 3rd day, then we can give the trigger with HCG once we find a better lining. Because sometimes the endometrium takes little longer to get ripened with estrogen in some patients as compared to with the others. And then we go for the IUI and of course luteal phase support for the patient. In a clomiphene citrate cycle, again, clomiphene citrate is not thrown out of the window. It is still a good drug to be used. Start from day 2 or day 3. And again, once you have a good follicle, that is the time you start with estrogen tablet in thin endometrium, tracking of the endometrium, of the follicle. And generally with clomiphene citrate, the follicular size goes slightly bigger. So it takes little longer. So you probably, although it can also cause thin endometrium, but if you have added estrogen to it, because it is so in those cases you get little 2 or 3 days extra for the estrogen to act on the endometrium, and then you give the HCG and then IUI 36 hours later. Now, another thing is, in suppose PCO patient hai, aapne letrozole diya. First thing is, the PCO patient ko we must start her on metformin. Any time of the cycle, any time she comes, she's PCO, anovulatory. First thing we should do is to start her on metformin. 500 milligram twice a day, very comfortably she can start. There are no side effects. Slowly we can also increase the dose. Some patients may start ovulating just with metformin. Else, we can put them on maybe letrozole or clomiphene. Suppose they are not responding. Metformin diya hai, letrozole diya hai, clomiphene, but she is not responding. She has resistance. Then we can go for something called a chronic low-dose gonadotropins. I will not be very happy to start. जैसे हमने letrozole दिया, कुछ response नहीं आया, then start gonadotropins. Even if we have to start, it should be low dose. If we start with higher dose of gonadotropin, like 150, then what will happen? It is a PCO patient, and then all follicles are getting food, and all follicles can come up, and then you can land up not only with multiple follicles, but also a risk of OHSS. So all that problem can come up. So how do we start? We start with 37.5. You can either give HMG, no problem. When I say 37.5 units of FSH or HMG, both have 37.5 FSH in it, right? So we give once a day for 5 days. After 5 days, we do the ultrasound. If we find a dominant follicle, that means one follicle is responding to this much of food. So we continue with the same food. So 37.5, we continue, right? If we don't find a dominant follicle, then we increase the dose to 75. Again, give it for 5 days. Most of the PCO patients will respond to 75 units daily for 5 days. Once we see a dominant follicle, then we continue with the same dose till this follicle becomes 17, 18, 19 millimeters. And that is the time we give trigger with ACG and IUI after 36 hours. Monitoring generally is done by ultrasound in PCO patients. Sometimes we can also measure the E2. So E2 will also tell us if you have a follicle growing well, and that will guide us for the monitoring. So I think my time is getting over. Okay, and then we see this PCO patient. Now this is a PCO patient. This is a PCO patient, but this is a multifollicular ovary. So sometimes we get the report from the radiologist saying that it is a PCO patient, but with a picture like this is not a PCO patient. So we must also depend on the clinical history. In fact, ASHRAE went one step ahead, saying that ultrasound should not be used as a diagnosis for PCOS in those with a gynecological age of less than 8 years. That means उसको 11 साल में मेनार्के हुआ, 8 साल, 19 years is her gynecological age is 8 years. So till the age of 19, if she had menarche at 8, ultrasound should not be used for the diagnosis of PCOS because the ovaries are bulky, they are studied, and they can be misdiagnosed. So only with she has irregular cycle, she has any signs of hirsutism, hyperandrogenism, so that should only be the criteria for the diagnosis of PCOS and not the ultrasound. This we have already discussed. So, all right. Again, can be used high doses of letrozole. There are some publications. There are also some publications where they start with lower dose of letrozole, and then they every 5 days they double the dose of letrozole. There are good, strong, high evidence publications can be used. However, we don't use it at our center. Again, letrozole with metformin, with gonadotropins is a good combination. We use it all the time and we get good results. So then, of course, in the IVF patients, we do use all the gonadotropins, we use agonist, we use antagonist. Just a small thing I would like to say. When I say 75 units of HMG, urinary HMG, that means it is 75 units of FSH and 75 units of LH, right? So we are still getting only 75 units of FSH, which is equivalent to 75 units of highly purified FSH or recombinant FSH. When I say recombinant FSH, that means it is produced in vitro in the lab. When I say urinary molecule, that means it is derived from the urine of postmenopausal women with FSH, LH are high. And then, of course, we have urinary SCG from pregnant women, urine of pregnant women, and recombinant SCG, which is produced in the lab. Which one we should use? Always a question whether I should use recombinant or I should use urinary. Of course, recombinant will have better batch to batch consistency. That is the one advantage of recombinant because it is produced in the lab. ये human के ऊपर dependent नहीं है. Urinary can have batch to batch inconsistency. However, when we look at the costing of both and when we look at the publications, we have realized that whether we use urinary or we use recombinant, the take-home baby rate does not change. And then, of course, we have antagonist and agonist, which we can use in the induction of in some cases, we can use antagonists, especially in IUI cycles, and we can discuss at, if there are any questions, we can discuss in that. So thank you very much. And if there are any questions, we can definitely take them. Thank you so much. Thank you.
That's wonderful session, ma'am. You have elaborated everything in a very simple manner, right? Starting from the evaluation, then different types of ovulation induction, and where we have to add estrogen and how to improve the endometrium of when the lining is thin. These are clearly very important points for all the budding gynecologists who want to practice ovulation induction and practice infertility in their practice. And definitely the dose of gonadotropin should be adjusted according to the age of the patient, the weight of the patient, so that we don't land in hyperstimulation and face the consequences of it. More than hyperstimulation, when we are stimulating the woman per IUI, we should also look at the multiple pregnancies, which we want to avoid definitely. That was a wonderful session, Dr. Meenu Agarwal, and wonderful. Thank you. Thanks for having me, and wish you all the best for your elections. And I hope to see you as a vice president.
Thank you, Dr. Lakshmi.
And I also want to thank Dr. Sandhya, who has been coordinating with all of us, Dr. Vaishali and Dr. Charu, for organizing such a wonderful academic session.
Thank you. Thank you very much. Thank you for your kind words. And yes, I agree with you. BMI and age, two factors we have to keep in mind when we are stimulating. Very nicely put. Thank you.
Yeah. Thank you, Dr. Meenu, and all the chairpersons, Dr. Lakshmi and Dr. Nalini. Wonderful talk given by Dr. Meenu as always. And we have with us now Dr. Vidya Thobi. Madam, are you here?
Yes, I'm here.
So we would like to welcome Dr. Vidya Thobi. Madam is guest of honor for today's program, and we request Madam to say a few words. And Dr. Vidya Thobi, as you know, is very, very popular personality, and we at POGS absolutely adore her. And she is friend to all of us. She's right now President Kasoga. She's chairperson. She has been chairperson, Food, Drug and Medico Surgical Equipment. We have done chairperson post together with the Madam, Meenu Madam and myself, and those were some of the best times we spent together. And so much we have learned from you, ma'am. You also won the Best Committee Foxy Award during our tenure. And right now you're the ICOG Governing Council member. You won Foxy Champion Award in 2019. National Corresponding Editor Jogi, Organizing Chairperson Kasoga 2023. And Secretary Bijapur OBGYN Society in 2007. Madam has numerous publications and papers, and she's organized a lot of various CMEs and workshops. She's a postgraduate and undergraduate teacher. So, Madam, welcome, and we would like you to say a few words and give us your blessings.
Thank you very much. And it is always a pleasure to be associated with Pune OBGYN Society. It is such a vibrant and academics it takes. And I must congratulate Meenu Agarwal. She has done wonderful work in her tenure as a president. And now she is connecting each and every part of country. And what to say about Dr. Vaishali and Dr. Charu? They are also equally very good friends of mine, and really they have put in very good work in their committees as well. Perinatology committee, as we have seen, that it has done wonderful work. And Charu, she is doing wonderful work under her committee, that is a breast committee of Foxy. So today, the cutting edge, I just listened to Dr. Meenu, her talk, and she has such a nicely simplified the various ovulation induction protocols, various evidence-based inputs of various drugs. So I'm very much thankful that I could listen to her that talk, because as a food, drugs and medical surgical equipment committee, these drugs always fascinate me. and newer drugs have come, even the micronutrients we use during infertility treatment. So all she has included in her talk. So I congratulate her. I wish her best in her whatever she wishes come true. And I would also love to see her as a vice president. Even equally, I am also appealing for my vice presidential means candidature from the south. So I request the two societies who have joined today, that is Hyderabad OBGYN Society and Vijayawada OBGYN Society, to nominate me, the president and secretaries. They have joined here, and I really welcome them. Sometimes to my state also as a speaker, Dr. Padmaja, then Dr. Kavita, they have joined here, Dr. Ananta Lakshmi and Dr. Lakshmi, and they also are a very good friend of mine. Dr. Nalini, who is also chairing the session, she is also very close to me. I must say that we have shared very nice moments with each other. So I again congratulate for this cutting edge, and I hope that this cutting edge is going to reach our Karnataka as well. So welcome everyone here, and thank you very much for inviting me as a guest. Thank you very much, Vaishali. Sorry, I
Thank
could
you.
not open my video just now. I
Yeah,
opened.
yeah.
Thank
Now,
you.
now we can see you.
Hi,
Thank you,
ma'am.
Dr. Tobi,
Thank you.
madam.
Mm.
Very kind-hearted, very warm, very gentle, and she's been the president of Karnataka Association of OBGYN, which is a very, very, very big post, madam, to have so many people under you and to manage those conglomerate of all the societies in Karnataka. So, and thank you for your good wishes. And
Thank you very much.
yes, yes. And best wishes to you as well.
Thank you. Thank you. Thank you. Hope we'll work together. Meenu.
Yes.
Thank you.
Yes.
Thank you.
Thank you, Vidya madam. Best wishes to you, and you definitely deserve the best. And it was truly a great happiness to see you here on the screen finally. And I know you're juggling today between ICOG and us, but we are truly grateful to you that you could join and be with us today. Thank you, madam.
So after the ovulation induction protocols, we have managed to make our patient pregnant, and so now we delve into the caves of intrapartum and labor care. So for the next session, I call upon Dr. Kavita Chalsani. She's our first chairperson. She's the secretary of Vijayawada OBGYN Society. She chief obstetrician and endoscopic surgeon, Shri Ram Hospitals, Vijayawada. She's also the core infertility specialist in Shri Ram IVF Center, Vijayawada. She is the treasurer of Andhra Pradesh ESAR. She's performed almost 8,000 laparoscopic surgeries and 500 hysteroscopic surgeries, and is a faculty in major laparoscopic conferences like RAGE. Welcome, ma'am. Our next esteemed chairperson is Dr. Ananta Lakshmi P. She is the professor and head of the department GMC Vikarabad. She is a consultant in MediHub's Kokapet, that is Hyderabad. And at present, she is a joint secretary in the OBGYN Society of Hyderabad. Welcome, ma'am. So now I request Kavita, madam, to please introduce our next speaker, that is Dr. Padmaja, madam.
It is a pleasure, actually great pleasure for me to introduce our own and my own Dr. Padmaja ma'am. Actually, I look up to her as a great human being and a great IVF specialist, and there are so many things which I can really add to. A person who's so humble, down to earth, despite the knowledge she has, which is an ocean. And currently, she is the president of Vijayawada Menopause Society. She was the founder. She is the founder, chairperson, chapter of ISAR AP, and that is my dearest thing of closeness with her. And then she was the past president of Vijayawada OBGYN Society, ex-secretary of FOX, and then member of Endometriosis Committee, FOXy, member of HIV/AIDS, executive council member, IMA, and so many things. And in the awards, she won the first prize in IAP quiz at Warangal. And it starts
Thank
off
you, Kavita. That was
1990. No, ma'am, I have to tell. And then the most important thing is Times Icon Healthcare 2023 award from none other than Muppavarapu Venkaiah Naidu Garu, the 13th Vice President of India, in recognition of lifetime service in women's healthcare. And her special interests are cell biology, reproductive endocrinology, learning, and teaching. It's like she can teach so well. Yeah, with this small introduction, and among the publications.
It's okay, Kavita. We will not waste time on that. Can I share my screen? Yes. Thank you. Just a minute. This one. Yeah. Can you see this?
Yes, ma'am.
We can.
Yes,
Okay.
we can see.
As I'm really thankful for the Pune OB-GYN Society and Kavita for giving me this time. The thing is, Dr. Meenu is a very difficult act to follow because she, in a very calm, cool way, she puts in a lot of material and you don't realize how much it is there that she's very comprehensive speaker. Anyway, intrapartum care for joyful motherhood. What has changed essentially is that the WHO has taken into consideration that intrapartum care, every woman deserves the best care that is possible to be given. So it does not, for having a successful birth, that means a complication-free delivery process where the mother and the baby are healthy. What is not needed is not like something exotic like water birth. So there are some minimum basic criteria, irrespective of the socioeconomic status, irrespective of the place the woman is giving birth, that this is the minimum basic thing that we should be providing her to make the birth process experience that she will not remember like a horror story. So many organizations came forward and gave us this guide of essential practice by the WHO in 2015. And I would like everyone to just go through and flip back after you've seen this presentation. So the idea is to improve quality of care around the time of birth, because most of the stillbirths, maternal and newborn deaths occur with problems that happen during childbirth. So if a strategy we have to take care of this part more than antenatal postnatal care, we will be rewarded much more. So all of you know the partogram. The partogram was developed in the 50s and 60s, where the Friedman's curve was given, where it was assumed that after 3 centimeters dilatation, the cervix will dilate every hour by 1 centimeter. And so if there is a lag of from 3 centimeters, if there is a lag of 4 hours, it is an alert line. If there is a lag of 6 hours, it is when action should be taken, and we should do something so that the dilatation goes along this curve and the woman delivers. So between 4 and 10 centimeters, it was assumed that cervices dilate in women who do not have complicated births at 1 centimeter per hour. So to enhance that, whenever the dilatation is a little slow, drugs like anticholinergics like valethamide or atropine, hyoscine, buscopan were given. They basically are very selective. Unfortunately, the selective dose is lost at high doses. They're basically anticholinergics because they're competitive antagonists or ganglion blockers and neuromuscular blockers. So drotaverine was one more drug that was compared in the duration of labor, and these in randomized control trials given in the active first stage, it was considerably shorter, and the dilatation was much faster when we gave it in, of course, multigravida compared to primigravida, and the side effects were comparatively very less. But then WHO started looking at the BOLD project. were better outcomes in labor difficulty. In Nigeria and Uganda, 13 maternity hospitals with 9,995 women in spontaneous labor presenting at cervical dilatation of less than 6 centimeters or undergoing induction. So you can see this was a study done in almost 10,000 women. And what I would like you to have a glance at is the red lines and the green lines. So these were the original partogram alert and action line. But when these women, these 10,000 women, every one of them, their cervix dilatation and outcome was monitored in a prospective way without us being biased. Excuse me. You can see that the red lines are the ones which had complications. The gray lines are the ones which had no complications. But you can see that there are equal number of gray lines after the action line and after the alert line. In fact, there are more number of gray lines than there are red lines. And most of the interventions happened here. So that means adverse effects will occur and good things, I mean, people will deliver vaginally without us having to do anything if we give them enough time. And we have to remember this Robson's classification, I'm sure you all know, but I like this picture because it, if you stick this on your labor room board, it is so easy. Group 1 is singleton in labor. Group 2 is induced cephalic singleton or who had an elective section. Group 3 is multi in labor, single cephalic. Group 4 is multi who is induced or a section was done electively. And group 5 is one with previous section. Group 6 is breech. Group 7 is breech multi. And group 8 is multiple pregnancy. Group 9 is transverse lie. And group 10 is premature. So if you look at these different groups, you can see that in women who are nulliparous, if you take this as an action line, most of the women will have a much slower progress in labor. And if you believe that we have to intervene at the level of the action line, we will be using a lot of drugs in this group. And even if you look at the multi, quite a large number of them are beyond our action line. So what this, and when we look at what is the sensitivity, what is the specificity of these alert and action lines, you see when the alert line is not crossed, or even if the alert line is crossed, there were no adverse outcomes in almost 4,053 women of the 9,000. Even after the action line is crossed, almost 1,000 of them did not have any adverse outcomes. So if they do not have any adverse outcomes, if we just give them time, why are we making it medically so aggressively? Why are we after them to deliver fast? And you can see the sensitivity is so poor. It is only 19. So this is not at all a sensitive tool for us to take action. And therefore, the WHO Care guide is a single page, easy to use guide. And I will just take you through this. There's not much. It looks complicated, but it's very easy to use. So basically, the first section is about the identity, the name, the parity, when the labor was onset. And active labor has been now reclassified as only after 6 centimeters dilatation of the cervix. Were the membranes ruptured? Are there any risk factors? So if you fill this, you know if she's a low risk patient or a high risk woman. And all these work for low risk women. And what is the, this column is all about what we need to be alert for. So most of the emphasis is that if we support women well, they go through labor beautifully. So if there is no companion, if there is no pain relief, if they're not taking orally, and they're constantly lying down, so all these are not good for labor. So all these are shifted to N. And if we write it down and circle all the alert ones, we will be able to take active steps. Provide them with a companion, ask them and provide them with a pain relief, make sure that they're well hydrated, and definitely in the first stage, mobilization is what is necessary. And if we look at the next section, it is about the baby, the heart rates, the presence of deceleration, amniotic fluid, whether if it is meconium or blood stained, it is abnormal. If the fetal position is posterior or transverse, it's abnormal. There's a big caput, there is big molding, these are alert. So we don't have to tell our nurses or our midwives or our duty doctors that call me if this is there. Because if they are diligently charting, as soon as they write it, they know if it is fitting into this, and if it is alert, the consultant will be informed. And we are looking at the woman at their pulse, BP, temperature, urine, whether there's proteinuria and acetone. And each of these is assessed, especially these are assessed once in 4 hours. These you monitor them hourly, and this also 1 hourly. Looking at the contractions per minute. If the contractions are less than 2 or more than 5, we will be informed. If the contraction duration is less than 20 seconds or more than 60 seconds, it will be. And the most important thing is the cervix. So at every point, how much? We are going to do a PV only once in 4 hours. So if at 5 centimeters, she stays only at 5 centimeters more than 6 hours, then we need to do something active. If at 6 centimeters, in spite of good contractions, if it is only she stays for more than 5 hours, then only we need to do an active intervention. So you can see the timings that are written, and of course we can plot the descent along with the dilatation, and you have a whole column for the second stage. And what are the medications that we're using? How much oxytocin are we giving if there are inadequate contractions? What are the other pain medications we're using? Any other medications we're using? Antibiotics? What are the IV fluids? And we need to give our overall impression about how this woman is, this lady is progressing, how her baby is doing, and any additional findings which we think are important. And we need to write down our plan. What do we plan to do about it? So it is only when we write down that our thoughts crystallize, and we can communicate this to the woman and have a shared decision with the lady, with her family, with her companion. And so in this protocol, in intrapartum care, when we need IV fluids, Ringerlactate is the fluid of choice, because we don't want hypotonic solutions. Usually around, if you have an infusion pump, you can give it around 125 ml per hour, or at 20 drops per minute. And the contractions should be 3 to 4 every 10 minutes. And if necessary, we can use oxytocin or Primoprost every 2 hours. And the pain relief, the proven analgesia of obstetrics is epidural. Now with epidural, but the only problem is that the skill should be there, and we need a constant anesthetist to be on call with us, with our nursing staff also being able to monitor and top up the epidural analgesia. And analgesia, the depth of the epidural that is being given can give a sensory block or a motor block. And there have been instances where ketamine was given for pain relief and patient satisfaction, because it causes some amount of dissociation. But without an anesthetist, I do not think we should be giving ketamine and other medications. And we can see the level of analgesia that they're having by whether they're having pain relief or excellent pain relief. And Dr. Daftari had popularized where anesthetists were not available, use of pentazocine or Fortwin along with diazepam dilute it in 10 ml and give around 2 ml slow bolus through the tubing of an infusion line. The only thing we need to be alert about it is that these drugs need an anesthetist to be at least available on call, and they can cause respiratory depression. And progress needs to, at every point of time, progress needs to be monitored and bearing down after she has the sensation and there is a descent. So for example, Mrs. S, I'm just taking you through a chart so that you can understand that it is not so complicated. She's para 2, spontaneous onset of labor, inactive labor, and she had rupture of membranes. Previously, she had stillbirth anemia. So you can see she did not have a companion when she came. She was not given any pain relief. She was mobile. So these are circled, and we made sure that she had treatment for these. And here the fetal position was occipito-posterior, it turned to transverse. As labor progressed, it became anterior. And you can see initially when she had come, her cervix was 6 centimeters dilated. After 4 hours, it had nicely gone up to 8, where there was a little amount of caput molding. And by full dilatation, in spite of having a molding, she was ambulatory all through. And only at 10 centimeters was she supine, and she had a successful birth. And pain relief was given, oral fluids were given, no IV fluids were given, no oxytocin was necessary. And whoever had monitored it has already also signed here. So like that, if we are able to have a good team to support women in primary also, especially if it's a multi, it will be much more easier. But what we need to have is go back to the basics and have enough patience. Make sure that she's not just lying down, give her good hydration, monitor the baby well, and have a companion so that they also are there with us. So for doing all this, it is important that we talk about a birth plan right from 34 weeks and start preparing her, because when she comes in labor is not the time where we can be doing it. Thank you, and I hope it was of some use to you all. And if you have any questions, welcome.
It was a very nice presentation, ma'am. Very nice presentation. Yeah, ma'am.
Very nice lecture, and lot of information about how to use epidocin and how to use partogram. I think the one session I attended very recently was on a ultrasound partogram. That is, they do pelvic ultrasound, or I think suprapubic, and they just keep on seeing the descent of the head. And that is how they keep on marking. And then, they say that cervical dilatation is not important. It is only the descent of the head which is important. So that was something nice, different that I saw in one of the international meetings. But your lecture was very, very nice. Lot of information. Thank you so much. Thank you.
Thank you. Dr. Meenu, the thing is that whatever we apply, it should be like applicable in almost all. So now what we are talking this year is inclusive. So it should not become so selective that it cannot be applied to most of the women. So what we need to is to take everyone forward with us and adapt practices which have proof.
Very true. I totally agree with you. That was just out of the box somebody presented.
Yes.
It was interesting for partogram when we are talking in context of partogram. Of course, it is not possible in our country with such a huge population. Every ultrasound for every patient is just impossible in labor.
Yeah.
But that's a nice paper.
It was very nice, and you have explained it very well. You made it simplified. Your conducting a normal delivery needs more patience and vigilance by the doctor rather than drugs. That was the message given by you. Very good. Thank you so much for that excellent talk. And I thank Dr. Meenu Agarwal, Madam, Vaishali Chauhan, and Charulata for having me at this dais, and looking forward to see Meenu Agarwal, Madam, as Vice President soon. Now, this cutting edge has become one of the best platforms to update ourselves. I congratulate the whole team.
Thank you, ma'am, Meenu ma'am, and Vaishali and Charlata ma'am for inviting us to be a part of this great program. Thank you so much.
Thank you, Dr. Kavita. Thank you so much for joining.
All the best, Meenu ma'am.
Thank you. Thank you.
I
Dr.
think with that,
Eloquent, your lecture was so mesmerizing. We loved it. Entire from beginning to the end. Very nice. Thank you.
Thank you, Charu,
Dr.
Vaishali, and
Padmaja.
Charu.
Yeah,
very
thank you,
nice
Dr.
speaking.
Padmaja, ma'am. Your lecture was absolutely, we were spellbound listening to you. And Pune Gynec Society, our members are definitely going to benefit by such a brilliant talk given by you. And thank you, Dr. Kavita and Dr. Ananta Lakshmi for chairing the session wonderfully. Thank you, Dr.
ma'am.
Nalini. You are saying something, Dr. Nalini?
Yeah, thank you, Meenu, Vaishali, and Charu for giving us the opportunity. Thanks a lot. And all the best, Meenu.
Thank you,
So
Nalini.
I propose the official
See
vote of
you, well, Vice President, soon, ma'am.
Yes.
Yeah,
All
I
the
think,
best.
you're getting good wishes for being the vice president. So that is really heartening and it is so good.
Thank you, Charu. Thank you, Dr. Ananta Lakshmi. Thank you very much.
So I propose the formal vote of thanks. I am so glad that we could have our guests of honor, none other than Dr. Charmila and Dr. Vidya Thobi, madam, as our esteemed guests of honor for today's cutting edge webinar. We thank them for their presence. We thank them for sparing their valuable time for being a part of this and for blessing the webinar. Our esteemed speakers, Dr. Padmaja, President, Vijayawada Menopause Society, and of course, our very own Dr. Meenu Agarwal. Thank you for those enlightening talks and those lectures. I'm sure all our delegates have benefited because of your talks. Our esteemed chairpersons, Dr. Nalini Bagul, Madam, Dr. Lakshmi, Dr. Kavita, Dr. Anant Lakshmi, have really been over here. They've been here to introduce our esteemed speakers. They have given their valuable inputs on the talks and they have spared their valuable time to be a part of our webinar. Thank you so much for being here. And most importantly, thank you so much for supporting Dr. Meenu Agarwal for her endeavor to be the Vice President Foxy. I'm sure that with the well wishes of everybody over here, we are going to achieve what we have set out to achieve. And we are always the strong pillars of support for Dr. Meenu, and we are always happy to be a part of this. So thank you, Meenu, for giving us an opportunity to be here. Dr. Sandhya is so meticulous. She always makes sure that the program runs fantastically. Thank you, Sandhya, for being the MOC. And of course, this program would not have been possible without BSV, Mr. Prasad Kulkarni. Thank you for the valuable platform that you give. Dr. Vaishali, I think there's not a single day that passes without us speaking. And so it's always a pleasure to see you along with talk to you. So thank you for your presence too. Thank you, everybody. Have a wonderful evening. Thank you.
Thank you,
ma'am.
I remember
Thank you.
Dr. Shanta Kumari ma'am, that you are the chief guest for this webinar. So she said, I may or may not be able to join because she was attending a conference. But don't worry, not just me, the entire Hyderabad is with you. So
Oh, fantastic.
so nice for to hear from her on phone. So thank you very much, and thank you, Dr. Kavita, for
It's
Dr.
always there, ma'am.
Ma'am, all the best for you too, ma'am.
Thank you,
You
Dr.
will definitely succeed.
And Dr. Lakshmi, yes, the secretary of Hyderabad Society. Thank you very much for joining. Yes.
Thank you.
Thank you.
Thank you all.
Goodbye.
Thank you all.
Bye.
Thank you. Love you.
Milan, stop recording.
Now we can chat for 5 minutes, I think.
Yeah, chat for 5 minutes. Charu, yeah, it was good.
Very
कैसा हुआ? कैसा हुआ?
तुम्हारा टॉक बहुत अच्छा, हर बार मैं नया नया सीखती हूँ.
सुनो ही मत, वही होता है. तुमको तो मुझसे ज्यादा आता है. दिस इज तो नथिंग.
नहीं अच्छा सब टॉपिक्स कवर कर दिया आपने. You have covered everything about the ovulation induction.
Okay, okay. Anything you feel I should add on in the my next talk, please tell me.
Yeah, I'll be telling you.
And next is on 19th March. Dr. Gaurav Desai has sent his topic.
Yeah, I read it. Yeah. That is the only one talk na. आणि प्रीती व्यास,
प्रीती व्यासला विचारायचं तिचं काय टॉपिक आहे?
but she's also speaking, क्या?
Dr. Anaita said she will speak on OBS and Gaurav will speak on gynec topic.
And
So we'll have 3 talks.
Acha, we will have 3 talks.
3 talks. So we have to finalize a chief guest of honor, and chairpersons.
Okay.
All from Mumbai Society only we'll have to take.
Mumbai Society this time, what we are targeting at.
Okay.
So everybody from there will need to take.
Okay. ठीक है. So 4 chairpersons we need, right? No, 6 chairpersons we will need.
3 speakers.
कसं करूया?
3 talks आहेत ना?
केदार कांदा है.
पुण्याचे पण घ्यायचे का? 2-3 पुण्याचे घेऊया मग.
अमेय, केदार.
We'll take Kedar, Ameya. You want to take Nagar Katti? You want to take?
We can take
No.
Nagar. No. Okay, no.
No. Then we will take that Priya Vora. She will join. She will come. Then we can take
this one we can take, but we already.
She will want to speak. है ना?
Yeah.
Anaita can be no chairperson for Minu's talk.
Yeah. We can tell her that.
Yes.
Yeah, you should call Nandita.
Chief guest we can call na Nandita.
Chief guest can be Nandita. Guests of honor can be.
एक रोहन को कहीं पर चेयरपर्सन ले सकते हैं हम लोग.
For your talk, we'll take Rohan then as chairperson, Meenu. And Anahita. चलेगा?
And 2 guests of honor.
Nandita Palshetkar.
वो next doctor she is getting installed ना अभी अपनी treasurer of Foxy.
Suvarna Khadilkar.
Khadilkar madam is getting
to call her.
as president. So we should take her as something in the MOGS का है ना.
So Nandita Palshetkar and Madhuri Patel you can take as chief guest and 1 guest of honor, I think. And PK
Madhuri Patel and Khadilkar will be more or less on same level क्या? या Secretary General is above the treasurer?
But you can take, that is fine. I think Suvarna Khadilkar also can be guest of honor.
Even इसको भी ले सकते हैं ना अपन अपना कोमल and Niranjan. We have not taken them.
We have taken them many times. Means हमारा उनके साथ अच्छा equation है. We have not taken Madhuri Patel, Khadilkar.
Yeah.
ये दोनों को लेना चाहिए.
सुजाता दळवी को भी बुलाना पड़ेगा फिर.
सुजाता दळवी ना बोले